So my name is Sammy Onyancha. I'm one of the doctors out of Germany. I'm going to talk to you today about the X1 system and why I think you should have that as part of your repertoire in the endoscopy. I have no disclosures regarding the topic, and I'm going to start with a question, which I usually like to send. What is the largest foreign body that interventional pulmonologists have managed to remove from the endobronchial system? Does anyone know? Thoracic surgeons. And there's a quote from Atul Mehta, which I really like because it kind of aptly represents the state of endoscopy as it is right now. With the advancement and the growth of diagnostic bronchoscopies, the rate of diagnostic surgeries have rapidly gone down. That's due to the fact that bronchoscopy as an intervention has had a high success rate in achieving higher diagnosis, diagnostic yield, and also being a safe intervention. That's also due to the developments of the scope per se, but also due to the systems that go into assisting the bronchoscopy. And one of those advancements is the X1 system, which I'm going to talk about today. So the X1 system, what does that mean? So the X1 system basically means the new bronchoscopes that are out in the market. They've managed to have bigger working channels whilst maintaining a small and sometimes smaller outer diameter. They're more ergonomic, meaning that you don't have to twist your wrist so hard in order to get into the nooks and crannies of the endobronchial system. And of course, you have a wide range of upward compatibility when you're talking about the older scopes. So the features that are available with the X1 system, some of them, and most of them actually, are compatible with the older scopes. What do I mean when I'm talking about the new features? With the new features, I'm talking about the TXI, the RDI BIMAC, and also improvement to the other features like the NBI, which you already know. A personal favorite of mine is the ability to use the full screen mode, which helps the endoscopy room appreciate what the physician is doing. So when we're talking about TXI, we're basically talking about texture and color enhancement. The image gets broken down into two pieces, so the texture and the brightness. Both of those pieces get enhanced, and whilst the image is getting stacked together, the color gets adjusted, meaning that you have a better refined image that comes out in the end. I'm looking in the crowd, I'm seeing most of you have iPhones. Anyone with a phone that's made in the last 5 years knows what an HDR mode is in the camera. HDR basically means your camera takes 3 photos, one low light photo, one highlight photo, and one normal. And then it superimposes all three together to give you the best quality of photo that you can get. That's basically what TXI does. Similarly, with my Mac, I like to couple these two things together because I find they go hand in hand in making the new white light. BIMAC means that the processor looks for the spots that are dark in the image because, as we know, whilst we're doing the bronchoscopy, we don't have a flat illumination. The endobronchial tree is not flat, so you have parts of the endobronchial tree that are more illuminated than the others. So BIMAC helps in that it searches for the darker regions of the endoscopic image and highlights them by making them brighter. What does that mean for an endoscopicer or for a physician? It means I get to see more from further out. It's like driving down a tunnel. Having better lights means you get to see more. Dr. Eberhard just talked about the pulmonary lesions in the peripheral bronchoscopy. In the peripheral bronchoscopy, getting there is equally as important as seeing where you are at. Because I can have a thin scope, but if I can't see where I'm going, I can't get the good results. The second part of the newer features with the X1 system is the RDI. RDI is the red dichromatic light. So RDI, I like to call it NBI 2.0. So using different light waves, we're able to see deep tissue vessels because seeing as the higher the wavelength, the higher the absorption, the higher the penetration of the light, they added amber light to red, which has one of the highest wavelengths and highest penetrations, but the lower absorption, so that you can have a contrast and be able to see the deep-lying tissue vessels. What that means is that you would be able to see the vessels that you would rather not see when it starts bleeding, or you would be able to pick out the best place to take your biopsy. I have a case I have a case about that. Here's a picture of the RDI in action, where you have the amber light around, and then where a deep lying vessel is present, you get to see it accentuated with red. So the patient case I want to talk about, it was a 72-year-old ex-smoker who came to our hospital. He had dyspnea, night sweats, and weight loss. And upon getting an X-ray and the follow-up CT scan, we noticed that he had a large a large tumor mass in the left main bronchus. Upon admission, he already had a respiratory insufficiency with an oxygen saturation about 87%. So if you look here, I can really highlight the benefits of the TXI because I'm in the very proximal region of the bronchoscope, but I can already see that on the left side, there's something going on. With the second picture, you can see the tumor that's going on, that's growing in the left main bronchus. And if you appreciate this picture over here, you can kind of see the vessels that are already there. I had a challenge of taking out this tumor without having a snare. So what I did is I did an RDI to help me know where the vessels were. And then anyone that knows me knows that I'm a big cryo fan. I used the cryo probe to slowly take out pieces of the tumor without having a high bleeding rate. The second photo in the middle is actually a fun photo. I placed saline solution whilst trying to cover up the bleeding, and then I had like a blitz effect. So I thought that was a nice photo to have. In such cases, doctors can be efficient because with the RDI, even if the whole endoscopic image is red, you already know where the bleeding is coming from because the bleeding spot gets highlighted, meaning you don't have to go with the APC in different places. Rather, you go on a specific target really quickly and you can stop bleeding as it starts. Or in cases like this, where you have to do an extraction of a tumor where you don't know what the vessels are, you can use the RDI modus to guide you into finding the best places to take out the pieces. So this is the X-ray before and after, and you can see the patient profited really quickly with the extraction, with the X-ray being hours apart. So with the NBI, that's pretty much already an established technique. Most of us already know what NBI means as using different color waves in order to highlight the superficial vessels. But what's new with the X1 system is that we're using LED illumination to highlight that. NBI has been there in the gastrological endoscopy, and it's made its way into the pulmonary endoscopy, where we use that to highlight different vascular networks. So looking at vascular angiogenesis, where we can see that where the vascular system starts changing, it's usually in turn parallel to the cancer building up in the lungs. And an interesting case that I had a couple of months ago was a patient who came to us, a relatively young patient, 47 years old. He had chronic cough, fatigue, and weight loss as well. He got a CAT scan, and the CAT scan showed signs of a bilateral lymphadenopathy. The CAT scan was a little bit suggestive of a sarcoidosis, and the serological findings were also in turn proving the suspicion of sarcoidosis with higher levels of ACE and interleukin-2. So he didn't have any prior medical conditions or any occupational exposure. So we did an endoscopy thinking that he would have a sarcoidosis. So this is the CT scan showing the lymph nodes. I have to mention at this point that the lung parenchyma was normal. That's important to the biopsy coming up. So when you look at the bronchoscopy findings, there's not really anything that's sticking out to you. The top photo on the left is after I did a mucosal biopsy. But when you look at the mucosa itself, there's nothing that really sticks out to you as being remarkable. The EBOS findings were pretty much the standard EBOS findings. You find some growths in position 7, 4L, and 10R. So what we ended up doing was a diagnostic bronchoscopy with a BAL, EBOS on both sides. And I have to mention at this part, we did a mucosal biopsy. I didn't want to do a transbronchial biopsy because I didn't want to risk the patient having a pneumothorax. So I just decided to do an NBI-guided mucosal biopsy. So these were the results that we got in the end. The BAL was suggestive of sarcoidosis, with him having 35% lymphocytes and an increased CD4-CD8 ratio. But the EBOS findings were non-conclusive. I remember the pathologist told me as soon as she got the results, you've done better biopsies before, because if you look at the lower slides, there's not really much material in it. But with the two upper slides, you can notice there's lymph nodes there. But as I said, we did a mucosal biopsy as well. So the eagle-eyed one of you, or the ones who can speak German, will notice that that's the clue to the to solving the riddle, so to say. So basically, this is the NBI-guided biopsy of the mucosa. So with a small biopsy, 1 millimeter from the mucosa, I was able to get the diagnosis of the sarcoidosis because in the mucosal biopsies, there was presence of non-necrotizing granulomas. So had conventional white light been used, the diagnosis would have likely been missed because there was nothing remarkable to see there. And there's been various studies showing the efficacy of NBI in lung cancer, but there's a paucity on the literature when it comes to NBI in detecting sarcoidosis and sarcoid-like lesions. So the diagnosis of sarcoidosis still remains a challenge, but with the newer NBI system, I'm pretty sure that we have newer modalities. Of course, we have the EBOS-guided mediastinal cryobiopsy as one of the emerging tools to make the diagnosis. But keeping it simple, with a normal mucosal biopsy, you can be able to get the diagnosis of sarcoidosis. There's even a current study going on in the USA where they're comparing white light against the new NBI modality in the diagnosis of sarcoidosis. So to conclude my talk, I want to mention that the advancement of the image processing and the assistance that we have with the X1, it helps increase the diagnostic yield massively. We have shorter procedural times because with the help of the TXI and the RDI, you don't have to really look at where you're going. First of all, you don't have to change the scopes to see further down. You don't have to start blindly using the APC to stop the bleeding. And also, you know where to place your targets because using the RDI, you know where to avoid when you're doing the cryobiopsy in central tumors or doing the forceps biopsy. But also, you know how to react when it starts going wrong. So as an all-in-one solution with the TXI and BIMAC for the identification, the NBI for the characterization, and the RDI for safety, the X1 gives you an all-in-one solution that has everything without the necessity of having a supplementary tool to making your diagnostic yield better. And with that, I'd like to finish with a very fun photo that I have. It's a quote from a friend of mine that says, having a bronchoscopy is easy like riding a bike, except the bike is on fire, you're on fire, and everything is on fire. And that pretty much adequately represents what I'm trying to say. Bronchoscopy can be easy if you have the right tools, but it can sure as hell be really hard if you don't have the help. Thank you.